Let your curiosity rise.
Mad Bricks webcast,
Where the human spirit flies. Mad Bricks webcast. Where the human spirit flies.
Hey, welcome to the Medbix webcast. This is Ramananam Raju. Bear with me. This Silicon Valley, we still the 6 o'clock here with a lot of plenty of sun here. So don't get all these spots are not something not wrong. There's too much light. Thank you for joining. That is a live from Silicon Valley, as you know. So that my name is Ramananam Raju. I'm the host. Let me introduce you my co-host. She's joining from Fort Myers, Florida, with all the hurricanes in between. She loves hurricanes, and she loses every year either a house or a truck. Let me bring her. So, Dr. Susan Davis. Welcome, Dr. Susan Davis. What are
Hey,
you losing this
Ramona.
year? What are you going to lose this year?
Thanks a whole lot. Knock, knock, knock. No, I don't love hurricanes. Nobody in their right mind. Yeah, I do seem to be a bit of a magnet for them, however. So let's hope for. They're actually predicting, even though the El Nino is going to be huge and all that, but here on the Gulf Coast, I think we're gonna get by with probably not even one. How about that?
Yeah. So, that one of the things is that Florida, one of the things I used to go to Tampa and Ocala, Florida, that's a bugs. Oh my God, I remember the bugs. That's a nightmare. I couldn't even sleep anywhere. Oh my God, that's remind me like India, all the mosquitoes, everything. Oh, this is not my place. Florida people are immune to this kind of
Yeah,
things.
you like to bring up all the wonderful, fun things about Florida. So, that
Yeah,
doesn't hurt our feelings. We're not sad if a bunch of people don't want to come here.
yeah.
Hurricanes, mosquitoes,
Yeah. You don't want people to be.
alligators, sharks, we have
Alligators,
all the
like
fun
that.
things. Jellyfish.
Yeah, but I like alligator. I ate a fried alligator one time. Oh my God, it's so
Yeah.
good. It's very good actually.
Yeah, it's not a huge I'm not a big fan. I mean, it's just like a rubber band. It doesn't taste just like chicken like everybody says. But I really don't see the point myself. But
Okay, let me introduce you. There are your two beautiful nurses and beautifully, highly talented nurses joining cardiology nurses, specialized in cardiology. Susan is already, both of them are pioneers in that, in my view. Let me introduce you a little bit. Our name is. Uh, Tonight on MedBix webcast, we are honored to welcome Karen Denise Walker. Karen Walker is a cardiovascular executive, registered nurse, a AI strategist, and a healthcare transformation leader with more than 30 years of experience in cardiovascular services and hospital leadership. She currently serves as a director of cardiovascular services for the county of Santa Clara, very few miles from here in Silicon Valley. I have not met her, but it's not that far. Throughout her career, she has led major cardiovascular programs at institutions including HCA Healthcare. I didn't know that she is an HCA. Rush University Medical Center, that's at Chicago, I think, and,
Chicago.
and the Detroit Medical Center. Her work focuses on improving patient outcomes, increasing operational efficiency, and helping hospitals keep critical cardiovascular programs financially sustainable. Karen is also founder of Cardiology Business Solutions and a creator of the 5-step cardio profit blueprint. I want to know what that is. Helping the healthcare systems use innovation, data, and AI driven strategies to improve both care delivery and financial performance. Let us welcome Dr. Karen Denise Walker. Welcome, Karen.
Hi, Ramona. Hi, Susan. How are you both?
Yeah,
Wonderful.
welcome to the
Welcome.
welcome to
Yeah.
the Mad Pigs podcast. Tell us a little bit about your background. Just did I miss anything? You are everywhere, all over the place,
Yeah, it's
including my hometown, Atlanta. You were there. I didn't know that.
yeah.
In my
It's
hometown, Chicago.
oh my. Okay, yeah. It's been a whirlwind. I'm not sure where exactly all the time has gone. I am a Chicagoan, born and raised there. on the south side of Chicago. Worked in all of the Region 11 hospitals, from U of C to all of the hospitals in the hospital district, Rush, U of I, Cook County. Did some work at Northwestern. Mercy Hospital and Medical Center, Trinity. So that's where I really got a lot of my background and upbringing as nursing, and then really diving into cardiology. I was a traveling nurse. I shared with Ramona for about 13 years.
Wow.
And, I traveled, had to get out of Chicago in the winter months, which are December through May.
I have that
December
that
through
memory,
July 31st.
traumatic
Exactly.
memory I have during the RSNA radiology conference December month. Oh my God.
Yeah.
Chicago people scared me at that time. How do they live?
Quite cold. But you do have to make sure that you have a fur, right? Because whether it's used or new, you've got to have one in order to bear the winters. But I would always go to a warmer climate during the winter months of Chicago. So I was in Hawaii for a while, 6 months there. I then ventured to Los Angeles. Then I went from there to Atlanta. And from Atlanta, I was in Florida. And so I just did a lot of moving around. I went to Detroit. All of these times, I was really focusing in on cardiology. My background is intensive care nursing, SICU. Certainly, Susan, you can appreciate this when patients are coming out of the operating room, and I would get report. They would say that, there's the IMA to the LAD and the SVG to the RCA. And I'm like, what the hell are you talking about? So that's when I really dived into cardiology and the cardiac cath lab. And then that's where it really took off. So I got a lot of training in the cardiac cath lab at Mercy Hospital and Medical Center. Kind of the rest is history. I decided to really dive into cardiology. I really like cardiology a lot, and really wanted to help organizations to improve upon inefficiencies, help them to grow their volume. Really, look at cardiology as a whole service line versus siloing, right? Because certainly, the patient comes in through the emergency department and they always get an EKG, right? And, depending on what's going on with the EKG, they could get a stress test. So all of these different components really should be part of a cardiovascular service line. The patient would have an echo. If it's high troponins, certainly the patient would go for a cardiac cath. So it's all one service line. So the key that I tell a lot of hospital organizations is not to really grow the program per se, but the first step is really to look at where are you on that continuum of cardiovascular care. We have fantastic doctors. We have a great healthcare team. However, have you dived into cardiology quality? Do you know your numbers with STS? Do you know the National Cardiac Data Registry, whether you're part of CATH PCI, whether you're part of the EP component or module within the NCDR? So all of these really compromise the entire cardiovascular service line performance. Is there leakage? Right? Because we can buy all the toys for the cardiologists, which is they always want a new toy. But you really have to make sure that you're capitalizing on the reimbursement and getting that money back for charge capture.
Karen, just quickly, when you talk about a cardiovascular service line, would you consider the acute, you were mentioning more than the acute care environment rather than surgical? I mean, cath lab, is there a line there? Because I know in different, across the country, we'll have cardiovascular care as a service line through acute care, as well as sometimes a siloed entire other cardiovascular service line that will be surgical, robotics, more invasive type cardiology type stuff. Do they separate that way? Is there a standard way that those service lines are separated?
Well, I'm sure you all can certainly appreciate when we were doing endorectomies in the carotid endorectomies in the operating room, when we were doing distal left mains or proximal left mains in the operating room, when we were performing aortic valve replacements on patients, 65, 70 in the operating room. All of that has been taken out of the operating room and it's being done in the cardiac catheterization suite, right?
Oh,
They do carotid stenting in the cath lab. We do transaortic valve replacement now in the cardiac cath lab. So, I'm more on the other end, Susan. So I'll say that surgery has to find their additional niches because we pulled a lot out of the surgical area.
that's a big win for
Fascinating.
cardiologists. That's
It's
a win for
fascinating because you gotta,
cardiology.
and Ramona, you got to think about the scope of practice who was in both spaces. And now, I mean, there's been, Karen, I'm sure you can speak to this, the training and the cross training. I mean, those are some, it's not just, walk in the park in the cath lab anymore. I mean, that's some pretty hardy stuff that they're doing over there. And the teams that are there, it's a real specific set of skills.
That is a big win for cardiology. But Karen, I don't know, both of you are more familiar, both of you. But one thing I noticed, I remember those days when cath procedures used to be get paid quite a bit. Then dramatically reduced it. One year they reduced it to like a $200, $100. Doctors are so frustrated. They do so much. They get paid for for example, narrow conduction study. They pay 10 times more than a cath lab, which is the life and death situation there. Uh, the reimbursements of the cath lab, reimbursements for a lot of other cardiac procedures went down. What is that dramatic shift? Even though you now you're saying you won a lot of things, a lot of surgery people came back to the cardiology, but still there is a lot of downward reimbursement structure there, right? Both of you, yeah, I that's what I used to focus on, money making system there.
Yeah. So the reason for that is one, there's a lot that plays with that. One is market saturation. There's pretty much a cath lab on every corner, if you will, of a hospital where hospitals are. So the market has become very saturated. Certainly, just basic left heart caths are not as prominent as they were in the historically due to the pharmaceuticals, Lipitor, and those anti-cholesterol types of medications. And then certainly people are more wiser now. They're trying to correct their health and they want to do better. I think certainly when transaortic valve replacement came out and that was being done in the cardiac cath lab, I want to say it was in the mid to early 2000s, like 2010, 2015. And that's when the reimbursement was very, very high. Now the reimbursement for transaortic valve replacement has dramatically decreased because it's the market saturated. And CMS is not going to pay what they paid before to 88,000 hospitals that are now doing it in their cardiac cath lab suite. So I think the niche is to capitalize once you get all of your ducks, if you will, in a row, and you have a solid foundation where you can handle the growth, meaning that your quality is in place, your throughput is in place, your efficiency is in place, your charge capture is in place, your access to care for cardiology, both pre-hospital as well as post-hospital, is intact. You have a cardiac rehab center where you're able to send your patients. After all that is intact, then you can start to add on additional volume and look at other types of programs within CV.
Speaking of specialty area, I mean, Karen, you just yourself, when we started the show, you talked about your travels. You traveled as a nurse. You worked all over the country. You worked in ICUs all over the country. And now here you are. What a secret gem. I mean, to have a nurse, no offense, I mean, knowing what you know from the clinical side, I mean, this is like, you must be like seriously the gem, because when you understand the clinical side as well as you do from as many perspectives, and I can tell you something, if you stay in one healthcare system, Romana, every healthcare system, unit to unit has a culture, campus to campus has a culture, much less state to state, right? And I mean, look at from Santa Clara to Rush in Chicago, South Side of Chicago, very different cultures. And the care, again, we started the show with, if you have a heart, you qualify. So after that dissertation, what I'm trying to say is, though you mentioned financially a ton of touch points, you have this clinical knowledge yourself. Now you're running the show with the dollars and cents. That is a very specific skill.
Yeah.
I mean, understanding, and we talked about this right before the show, the number of touch points, pre, during, post. Are you using AI besides you being the gem to pull all of that together?
So it's funny you say that, Susan, and the way that you're connecting the dots, if you will, are so spot on. Yes, I've worked in private institutions. I've worked in teaching institutions. I've worked in hospitals that are safety net hospitals. I've worked in academia. I've worked in research, all within cardiology. And then I've also had that background in frontline nursing in ICU. And so what I decided to do, Susan, and I'll answer your question in a couple of minutes, but what I decided to do was to go to Harvard and just take some AI courses for about 3 months. So that's what I did last year. I took 3 AI courses to see how to integrate AI into cardiology and not just bombard people with, okay, I didn't want, I have the experience and I'm the SME, and so are you, Susan, the subject matter expert, where when AI is hallucinating, right? So I think being in Silicon Valley, Romana, I get calls all the time from tech people wanting to be able to bridge. They're able to bring the data science part. They're able to bring the technological piece of it, but clinically, they don't know.
That's a big problem still.
Huge problem.
Huge problem.
Huge problem. So our advantage, Susan, is that we have the clinical knowledge to be able to help the IT and the those types of people. We're able to help them to pull it all together. And so I enjoy what I do. Right now, we're going through some changes at Santa Clara Valley Hospitals. It's a 4 hospital system. And we decided that we cannot do business no longer as usual, right? With the big, beautiful bill that came out, all of the cuts, the changes that went on in DC, we had to look at business differently. And so instead of having Open Heart in 3 of our 4 organizations, we decided just to have the hub and spoke type of model. So we're still formulating that and ensuring that we have a solid foundation before we move forward and grow our services. But it's quite interesting the way AI is able to integrate. In number 1, identifying additional patients. That's it, right? Going through your Cerners or Epics or Meditechs of the world, your EMR, and identifying patients with a AVA of less than 1, or an EF of 35 or less, or what have you, and be able to extrapolate that from your echo or from your EMR and say, here are the patients we've identified based on your clinical pathways, based on what your protocol that you fed us. And then you have those patients, and then you go through to do the follow-up. So it's really not eliminating any FTEs. It's ensuring that the process is more efficient and smoother and really capitalizing on what you have.
Yeah, and I would think, Ramona, didn't we have someone not long ago that was also speaking about kind of the incidental finding from calcium studies from, was it CT and or even just chest X-ray?
Yeah.
So that would identify, that would be was another way to identify more cardiac patients.
But let me ask you, both of you. I mean, you're expert in. Let me ask you. So, if suppose now all fee-based services, right? Some of them are capitation fee-based services that you offer, but if you don't have people, this is like a dilemma in the back and forth. You need more referrals, but you don't want to keep them there. That you don't want unnecessary referrals. How do they balance out that process? That is, like, that's a how do you the long term, the DRG regulations, you don't need to stay
Yeah.
that more than required, but and also you need, same time you need a patient flow. How do you balance that out?
Yeah. So as it relates to revenue, hospitals that are safety net hospitals or hospitals that are county-based or government, they're being subsidized by
Okay.
the government. So we're in the business to take care of patients. We're not in the business to say, do you have M-Care, or do you have private insurance, or do you have the blues, right? Blue Cross Blue Shield or whatever. We can take you. So we're taking care of everyone, and then you're subsidized on the back end. Now that doesn't take away from one really wanting to be efficient and have that throughput effective where patients are discharged within 23 hours or within 1 day. Transaortic valve replacement patients should be discharged within 24, no more than 48 hours, versus having the patient in the operating room, Susan, and open heart, which you're looking at a 9 to 11 day length of stay. Right.
Yeah.
So you're gone
That's
from 9 days to 24
amazing.
hours. It's amazing. EP procedures, patients with atrial fibrillation, EP procedures, or patients that are in HF3 or 4 stages, they need sometimes cardiac rhythm devices. And these patients are generally discharged, depending on what time of the day those procedures are being done, they're discharged within 24 hours. They may spend one night and that's it. So we're being more efficient. So that's helping as well, Ramona, as it relates to the longer length of stay and your capitation of DRG 313 of being only, $50 or what have you. And so we're becoming more wise, and technology is keeping up with us, and we are keeping up with technology. At least some of the hospitals are, where we're savvy to be able to have that patient go through the continuum of acute care, which is in the hospital.
Very interesting. Let me ask you. I know a lot of doctors. Some of them are, in Atlanta, for example, the Atlanta Cardiology Group was bought by Piedmont Hospital. The Piedmont bought the big groups. Now there are not too many independent doctors. There are some few of them here. One of the good friends of mine is practicing here in Silicon Valley. How do they survive? This is the reimbursements are single, the administrative costs, and cardiologists, they're doing a lot of internal medicine, of course, they do basic primary care. So how do you have some ideas that they do ablations and new procedures, they can do a lot more outpatient procedures they can do. Tell me, how do they increase the revenues and they can sustain themselves?
Well, I'll tell you, Ramona, that in the Midwest and probably the Southeast, physicians probably about 7 or 8 years ago rushed to become a part of the hospital because of the reimbursements, the cuts in reimbursement, and the physician fees were cut. Here in California, there is not a standalone cardiac catheterization suite. It's against HCI. Okay. So they don't allow that here in California. In some states, they do have, outpatient cardiac catheterization suites, the ambulatory surgical suites types of things. The physicians had to integrate with hospitals in order to maintain or in order to survive. They could not maintain their overhead of their office unless they were performing procedures in their office, like stress testing or echoes or, 12 lead EKGs. There's not a whole lot of reimbursement from those, but there are certain vascular types of procedures that you can do in the doctor's office, like veins types of procedures, but they couldn't survive. So a lot of doctors, certainly in Chicago, they were looking for hospitals to join in on because they had to let their practice go because of the reimbursement was just trickling down, down, down.
Okay.
You mentioned echo. I was thinking I've done a lot of work myself lately with echo teams, radiology, and all the imaging teams across the country. It sure seems like there's a lot of freestanding imaging centers popping up, and there's echo, just echo alone, non-invasive cardiology, freestanding. Everyone's going remote. Karen, everyone's remote.
Yeah, I wanted to add to what Susan said. Echo, for example, I think I used to offer that diagnostic services in Atlanta. Don't you think the echo should be offered in the primary care setting itself? Because a lot of doctors, I was talking with the cardiologists, they said the echo should go to the primary care. They can screen a lot more people now. What is your opinion on that? So she is saying, Susan is saying, echo is everywhere. No, is it a good or bad? That's my question to you.
So here's the thing with echoes. I'm in favor of cardiology being a part of it because that's what I know. What percent of echoes are positive or significant enough to keep a patient in the hospital? Not a whole lot. So that's why you're seeing the trend for diagnostic types of imaging remotely and on the outside. So can a PCP read an echocardiogram to decipher, here's a blood clot, what do I do?
Hello, AI. Hello, AI. Come on in. Talk out.
But what we did was, that's a good question, Karen. What I did was, we had a now echo that we can transmit that data to the video to the cardiologist, let them interpret instead of sending the patients. Maybe, as you said, that 90% maybe not positive, they're all negative. So they just give some advice. The cardiologist can give advice to them, or they can shift it to the patient into the cardiologist or hospital. So that is you became dark or something. You need to put lights on I
think what happened was.
Yeah. Okay. Got it.
I'm back there. Yeah. Okay, thank you.
Yeah. Okay. Now we can see you.
So back to Susan's point. So Susan, with the 12 lead EKG, it spits out automatically left bundle, right bundle, AV block, right? Third degree heart block. It'll give you a preliminary reading up there at the top. Whereas a echo is not going to give you that reading. Now, how we could possibly get around it is that the echo is being performed by an experienced echosonographer who identifies that there's a abnormal echo. Because if you look at all of the outpatient echoes that patients are coming in to outpatient centers for an echocardiogram, if the echosonographer identifies that there is a clot or there's some other type of abnormality, then he or she can certainly identify and notify the cardiologist.
Yeah, we're getting
because the PCPs have echosonographers in their office.
Yeah,
it's not an MA that's connecting the 12 lead, right?
No, I used to do mobile service. I used to send licensed echocardiographer. They take the machine and do all the testing, the PCP. Patients don't need to go to the, again, multiple places to get this exams done. That's one of the advantage of being, that is a lot of primary care thing is offered in a lot of special kind of services offered in the primary care office would be better
Well,
benefit to the patients, right?
I think we need to just, I think Karen's point, and to your point as well, Ramona, a lot of people think with today's technology, can't we just have anybody zap, zap, zap? Okay, there's your echo. I mean, you do have to have training. Everything
Training,
comes
yeah.
back to training. I just saw something in remote Canada. I think I read about it yesterday. They create. There was a cardiologist who created a cardiology in a Pelican case, right? So that they could send the Pelican case, open it up, and it had all as advanced, wearables as possible. Or, a super duper stethoscope, a wearable, an EKG, and then all of it would be transmitted. So you have to have the training to understand what you're doing. We can't just everyone pick up their smartphone and do a remote echo and think we're going to be okay.
You can't.
Training.
I'll give you some bad news for you, both of you, in that sense. There's a few blocks from you, Karen. My friend started a company called the Exo Imaging. That is this is almost, it can identify is a independent operator not a dependent on the operator. It is really AI can recognize all the abnormalities. It's coming. It's not all the way there, but there is a big less dependence on the operators is the key. Actually, tomorrow I'm interviewing a lady who is doing a ultrasound in space that she wants to do that less dependency on the technicians. They wanted to cut down that dependency.
Yeah.
Yes, Ramona, and I'm sorry, Karen, I didn't want to interrupt you, but a human still has to look at whatever that thing is spitting out.
Yeah, of course, yeah.
There's right now court cases coming in all industries that are using AI. There was a big one that was just in the news yesterday. It was like 1,500 cases globally where the case has gone before the judge. The one side didn't read the notes. The AI spit out the whole case. They went before the judge, and then they had to pull the whole thing back. And now this is going to happen in healthcare. We had a hard time interpreting doctors' notes before AI. So now ambient listening, right? So now you have ambient listening, and how lazy we get. I'm just going to speak for myself. You get pretty lazy using AI, and how many physicians, no offense, physicians, I love you all, but are going to go back and review all of those notes.
That is a big challenge. I agree with you.
Yeah.
That is a challenge itself.
It is.
So, what do you think of the hospitals in the future of hospital cardiac care? A lot of prevention is a big thing. Is the hospitals are doing enough for the prevention, Karen? Are they insurance companies promoting you, giving you hospitals, hey, promote this. We are going to give you a chunk of money for you to promote the well-being of cardiac patients. Are there any push going in that direction, or just the same as old thing and there's no well-being situation
Keep them
there?
sick so we can make some money.
So healthcare is always, as you know, Susan, is always the last system to get on board with anything new.
Yeah.
We were the last to offer remote patient and doctor until COVID hit. When COVID hit, then CMS starts reimbursing and approving remote visits. Before COVID, it took us years to try to do that. So what we don't want to do is be reactive and wait for a catastrophe to happen in order for us to move forward. I think that CV is still the number one killer, right?
Yes.
And so we need to shake, reset, and integrate AI into cardiovascular. We need to do pilots with the frontline team and the administrators, but you got to have the frontline team there at the table as well because they know the workflow. Yeah. But we've got to do it. We have to do it. We're going to have to do it in order to survive. We have to be able to identify those patients because, as you identified, Ramona, that more and more types of procedures are being shifted out of the hospitals,
Yeah.
either into a ambulatory surgical center, offsite
Primary.
center. Yeah. We're not doing, your eyes and knees and noses in the hospital setting anymore. All of that is shifting to the outside. And so even, like I said, not in California yet, but cardiac cath labs are built in other states because it's okay to do. But HCI has not approved it yet in California that I know of.
Yeah. Let me get into Susan's world. She does a resuscitation, CPR and resuscitation education training there. What do you think of this? The hospital that she always tells me that hospital, all of them are not trained into resuscitate everybody. So there's a big challenge there in the hospital systems. How do the cardiology should be spread across the entire hospital system, not just the cardiology department? That's what. Am I saying right there, Susan? You can expand anything that if I'm saying wrong.
I'm not. You're talking about a handful of different points in one sentence.
Okay.
So I'm not quite sure what your question was for Karen, because I can share with you, and Karen knows this quite well. When it comes to resuscitation, anyway, the cath lab is its own world. They don't. There's an internal battle quite often across the country. Do we call an overhead code blue for cath lab, Ramona? Because they're pretty much causing the problem when they're in there.
So Susan, can you come to my organization at one of my hospitals and talk about that?
Yeah.
Oh yeah.
Because I said we don't need a code blue. We don't need back in Chicago, my interventional cardiologist would intubate the patient if needed. My cardiologist, because we injected dye into the conus branch and the patient fibrillated, we didn't need to call a code blue because we were actually causing it, and we know how to correct it, right? So when you call an overhead page and you've got 88,000 people rushing into the cath lab, and you're saying, okay, but I need to step on fluoro to open up the artery, I need everybody to step out. No. So what we do we don't call a code blue because we can run our own code. Because we may say, I need a 2.5 drug-eluting stent. I need a 035 wire in order to resuscitate the patient. Give me a Impella or an intra-aortic balloon pump, right?
Yeah. So you stepped on a real can of worms here, or stepped into a big puddle, Ramona. So I know what you meant. So one thing that I talk about a lot, Karen, is the training. Often when it comes to the first few minutes of an arrest, respiratory, cardiac, whatever, it's critical care teams that tend to own that skill set. Mm-hmm. Yet what I talk about a lot is that we really do need to empower those who are there. And so what I'm referring to is I don't care what department you're in. Cardiac arrest doesn't care. The patient doesn't care about your skill set. They just care that you saved their darn life. So how about we recognize the problem, call for help, and act? But what Ramona's referring to in my soapbox is that looks really different everywhere you go. So the cath lab, you picked a hotspot, Ramona. That's a whole world. It's like the OR. They don't generally call overhead in the OR either. In the units they do an ED and ICU sometimes, but it's really like a formality, just kind of, so, and it's called, we talk about cultural, depending on where you are in the country, it changes hospital to hospital, campus to campus, system to system. But I'll wrap up what you were getting to, Ramona, and that was, Karen, that I like to see, my soapbox is that I don't give a darn where you are, what your job description is, that everyone should be able to manage those first 2 to 6 minutes. Mm-hmm. And let's face it, our BLS, ACLS, and PALS, no matter what modality you're using, doesn't do it. That's foundational knowledge. So ultimately, the take-home message is every team, especially your teams in cath lab, they really need to run the drills because it's specialized equipment in a specialized space with very specialized team members. And so we do these quick 2 to 6 minute drills just so that everyone has the emergency response plan for their area. So
I love that. 2 to 6 minutes.
That's
because that's key.
That's it.
Yeah.
That's key.
I love that.
That's my whole world. My whole world is the first 2 to 6 minutes of arrest.
I love
And
it.
then we make emergency response plans, Karen, for down to every room. So if a unit begins it, every room is different. Some have 3 beds, some have 2, some have weird doors, some have, awkward. So anyway,
Yeah.
bottom line is cath lab, Romana, crazy zone for
Yeah.
an induced arrest generally.
Correct. Yeah, it's generally induced.
Let us talk about another procedure, Karen. FDG, the PET CT scan, the rubidium scanners. I used to sell those, those PET CT, FDG, rubidium scanners. What do you think of that? Is it profitable, or is it outpatient you can do, or the inpatient, whatever it is? Is it PET CT, FDG? These are all cardiology department. It's a new thing that is it really viable in the operation side?
Well, cardiology for CT certainly is. I haven't heard of the other being integrated with cardiovascular offhand. That's yeah, I haven't heard that.
The rubidium scanner is for the heart viability. I think that I understand. I'm not I'm acting on the. I'm not a doctor only on TV. I'm a doctor. So,
Are you
I am
Dr. Welby?
well be.
Welby, MD.
Yeah. So what I know at that time, though, I'm a good device guy. So I used to see a lot of FDG devices and the glucose. They use the FDG is a glucose kind of thing. They give contrast injection and they check it's a nuclear thallium similar to nuclear thallium.
Oh yeah, VQ scans.
Yeah, nuclear scan.
Oh yeah,
very
yeah.
similar to nuclear scan, functional scans.
No, yeah.
So
Yeah, we
that's what I was thinking he was referring to. I just didn't know the name of it.
Either. Yeah, I didn't catch it, but yeah, we do Lexi scans, non-invasive types of cardiology stress testing, like your Lexi, thallium stress, those types of things. But really, VQ is more for pulmonary, right? VQ scans, because you're looking at the pulmonary arteries, the pulmonary veins, looking to see if there's clot there. So that's pretty much VQ scans. But regular stress tests with thallium or the iodine or what have you, yes, we do those as well. Yeah. Are they as accurate? I can tell you that what they show to the cardiologist is the area within the heart that has taken a hit or not. It will tell if the inferior portion of the left ventricle is viable. If it's not viable, then one knows that there's something going on with the right coronary artery, right? So each segment of the left ventricle correlates, of course, to the coronary anatomy of the patient's heart.
Karen, the 12-step program is for the people who are alcoholics and addicts. You have a 5-step program for cardiologists, the survival of cardiologists. Tell us what that 5-step cardiology survival guide.
Oh, she's talking about her business blueprint.
Business blueprint, yeah.
So I came up with a business blueprint because I wanted to, because of the experience that I had in management. And I wanted to try to help healthcare executives as well as hospitals streamline the cardiovascular services. So the step one is really looking at defining, where are you? That's step one. Where are you on the square? What's going on? Where's your leakage? Where is your access? Is there an access problem? Are there patients that are, being discharged without the appropriate type of care? So where are you on step one? Then pulling the team together, saying, okay, here's the data. Where are we going to start? What's the mission? What's the vision? Can we pull together what we're aiming to do to intercede or integrate with the organization's priorities? So you got to make sure that everybody's on the same page, because you don't want to thinking you're going in one direction and then the priorities and what the other C-suite is looking to do is something completely different. Once you've identified where you are in a baseline, once you've identified what the mission, vision, and priorities are of the hospital organization, then you can move to that next step and start looking at your quality. Start looking at how to improve quality, because really a successful cardiovascular service line has to stand on good quality, because everything is so transparent now. You can
What does
go
the quality
on.
means? What is a standard metric on the quality?
Yeah.
Give me one example of that.
Yeah. So when you're looking at quality, it depends on what entity you're looking at. So for cardiology, you want to look at our BI, business intelligence, which is the New England Journal of Medicine, which is your American College of Cardiology, which is your American Heart Association, which are all of the types of registries and other types of organizations where we go to say, what is the evidence base? That's how doctors operate. You know that.
Okay. Yeah.
They want to
Standard of
know
care.
what's the evidence base, what's the standard of care. Well,
Yeah.
it's in ACC volume 14, page 48, right? So that's what they look at. And so we have to make sure there's a solid foundation, quality, mortality. You're talking about readmissions. You're talking about morbidity. You're talking about length of stay, right? Because all of
Got
that
it.
ties into outcomes, efficiency, throughput, access to care, and then follow up.
Woo! That sounds like a blueprint right there. Check. You know what? That's the beauty of a blueprint, Karen, is you're telling these people, look, hello, I have 30 years. I've been all around the country. I've been in every cardiology from here to Kingdom Come and back. And now here's this blueprint that says, I know you're awesome. I can see you're awesome, but you might be missing one of these check boxes. So let's dump it all on the table and compare what you have going on right now today to this blueprint.
Yeah.
There might be things that are missing, or they might not be in the optimal order to get her done.
Correct.
So what a gift.
Yeah. And I think once you identify what you're going to be working on and what the outcomes would be, it's so important to have ownership, right? Because somebody's got to own it. You gotta own it. You got
in
to own it.
healthcare, you just we can mic drop right there, right? The ownership.
You have to own it, because then when you have ownership of it, then there's someone that you can, say, okay, you can go to that person. How are we doing here? What can we do? Let's pull the team together. And the team has to be it has to be a multidisciplinary team. It can't be us four and no more. It's got to be a multidisciplinary team that includes your frontline staff. It can't be all doctors making decisions. It has to include your leaders, your frontline staff who want to be, who want to be a part of it, to take ownership of it.
And I think that's tricky, Karen, because that word ownership, that's a big word in healthcare. I think people owning any project in healthcare is a hot potato. And add the pandemic and the ownership, the lines got a lot blurrier, who owned what, when, or where. And now post-pandemic, everyone's like, listen, one more grain of salt on the back of any one of these healthcare workers, they can't own anything. Sorry. But so now everyone's like, back to the hot potato game. Ownership is tough. But if we're going to improve, we need ownership with blueprints.
We have to. And the way to do that, Susan, is really to know your people, to identify where they are on that disc. Are they dominant, influential, steady, or conscientious? Really? Because each one of those have a trait. And when a leader identifies their colleagues, whether it's colleagues, leaders, or colleagues, frontline workers, then their drive is to do task-oriented things. And you can coerce them, if you will, to say, I need help with this. And guess what? You can put that on your evaluation.
Yeah, and I love that. And I think that's something that you know what, most healthcare systems have all kinds of leadership development, and they have the Myers-Briggs, and they have the DISC assessments. But if you have a team and you don't know their strengths and their weaknesses, and I think part of that grain of salt and ownership comes when we assign duties and tasks to people who hate said duties and tasks. I mean, they hate it. And then
They want to plan parties.
yeah, so I think again, back to dumping on the table and back to the check boxes in your blueprint. I think that should be one of them. Is really understand your team, know your team's strengths. In real estate, we say highest and best use, right? There's always a highest and best use for a piece of property, but there's a highest and best use for humans. If they're going to get into flow and really contribute to the overall outcome, then they
have to know your team. You
have to know your team.
Absolutely. Yeah. And you can utilize those influential people that like to party. Oh, guess what? I need recognition. Can you organize a quarterly outing for the team?
And then
can you come up with a recognition plan, right? So you can utilize those high eyes. Yeah.
My teams, I always say, okay, everybody, this is the hate session. What part of your job do you 100% hate? And let's dump them on the table, because likely something that might take me hours because I hate it so much takes the person across the table from me like 10 minutes, like, said spreadsheets. Okay, so I'm not a spreadsheet human. I will never be a spreadsheet human. I hate spreadsheets. And whenever I have to do spreadsheets, my whole day is ruined.
I'm a high D. I'm very dominant, especially at work. And my staff, I teach them the DISC. So everybody knows what everybody is. So I tell them, I am not offended when I come up with a bright idea and say, let's execute it tomorrow. I need somebody to say, Karen, did you think about? Karen, what about? Oh, right. Okay. Let's recorrect here.
I love it though, Karen, because I am too. And so I'm like, listen, that's why I have you buy me reins. It's okay to rein me in. Otherwise, I'm going to keep going.
Yeah. It's a discussion. I was supposed to present something. I'm going to skip for this today. It's a discussion. It was so good. So cardiac care is one of the most number one killer in the world. We need to spend a lot more time on it and understand this disease much more clear. And we need to come up with the frontline solutions for this. One of the things I wanted to ask you, Karen, is how much the cardiac care can go to the home. We are getting a new geo patch, for example, that I used to, and even monitoring and Holter monitor. They're all going home now. So you think that is a big savior for the cardiology in that sense for the lot of patients who are struggling with the cardiac problems?
Yeah. So it's going to depend certainly on your patient, the culture. Some patients, I'm sure you see it a lot here.
They're non-compliant, like me.
They're non-compliant.
Yeah.
But you also have those patients who in Silicon Valley are homeless with a cell phone, right?
Yeah.
I know my bill is $230 a month. I'm just saying, but I'm just trying to figure out how are you going to have a cell phone, but you are homeless or whatever. But whatever the case is, some patients are non-compliant. And we would get really a lot of patients for transaortic valve replacement procedures that were non-compliant, or patients that are very high risk that are coming in with acute myocardial infarctions, who we know we needed to put on the dual antiplatelet therapy post-care. But the question becomes, are they going to be compliant, right? I think it's a good thing, to answer your question, that a lot of these things are being sent home, but I think we have to be careful and ensure that whoever we're sending the patches home with, that these clients, these patients will adhere to the regimen. That's so key. Now, what goes around comes around. I don't know, Susan, are we getting back into Florence Nightingale or not? But,
well, I don't know, because now you bring up a good point, both of you, and it's now I'm kind of stirring the AI back into who's getting home devices and who isn't. So if we're only getting, if our data sets are coming from only certain groups of people, then everybody else that's not represented in that data set it's not going to work.
That is correct.
I mean, it's
That
just
is
not going to
correct.
work.
That was
You know,
number
yeah.
one thing that we were taught at Harvard. It wouldn't
Yeah.
be representative of the full population, especially in 2026,
2020.
right? It's no longer black and white. There's so many different races. So we have to ensure that when we're integrating and introducing AI, if it's predictive or whatever, we have to ensure that it's representative of the population.
And that's going to be tricky.
You know, Karen, you're in the epicenter of Silicon Valley. You're the central. Santa Clara is nothing more central than Santa Clara, right? So most of the people are here, younger population, like under 20, 25, 30 years old. You know, if you're 30, then they think you must retire here, right? As you know. So
that's old. That's old.
But they have these other problems of homelessness, drug use, rampant drug use. Do they cause us eventually they manifest into cardiac problems? And you think that you see that kind of situations in Silicon Valley?
We do see patients who are IV drug abusers or who are utilizing, I forget the name of the new drug that's out on the street, but they come in with acute coronary spasms.
Really?
Yeah. And sometimes they resolve on their own, sometimes they don't, and they would have to have a drug-eluting stent. But the question becomes, are you going back out to use drugs again?
Yeah.
So you have to kind of weigh it. Do we treat and ensure that we do? But if we treat, we're going to need you to be on this medication. Are you going to take the medication and be compliant and adherent to the medical regimen that your doctor has prescribed? Or are you going to go back and start shooting up drugs again or taking fentanyl or whatever they take these days?
That is a local problem here. Thank you so much, Karen. I think you gave us such a powerful education for all of us, and cardiology, which I love cardiology, that I spend a lot of time with the cardiologist in the business side of it.
Yeah.
And I'm still learning from you. You're a really true master. Both of you are too good. We need people like you, both of you in the world, to really lead this cardiac care in this world.
Yeah.
Needed to
I just want to thank you both. I think this was a perfect match because we were bouncing off of each other. Susan was diving into it. I just thought this was an excellent podcast, and I so appreciate you inviting me on. And thank you so much for making me feel comfortable. And just what I would say, and what I would want the listeners, the takeaway is that cardiology is not siloed. It is a complete system. It's not isolated any longer. It's everything is involved. And I think you talked about that earlier, Susan, where you got surgery, you've got this, but really it's all encompassing because it's the heart.
Yeah.
That's what I say. If you have a heart, you qualify.
You qualify.
Job security, Karen Walker. Job security.
Yeah.
So
I don't know. I'm really up there. Like Ramona said, that Silicon Valley is full of 25 to 30 years old, and they're living large and well. And here I am, almost up there with Ramona. I'm like, okay, but I feel great. I'm, very spry and energetic, and certainly don't look my age. So I just,
I'm more than certain then we have a thing or two up our sleeve for all those whippersnappers out in Silicon Valley that need to learn a thing or two about cardiology. I can guarantee you I can help with the first 2 to 6 minutes.
That's right. I would love that. I'm gonna tag you on LinkedIn, Susan.
Yeah.
Excellent.
Thank you so much.
We're coming to say hello for sure.
Yeah.
What a pleasure. What a pleasure, Karen Walker. Thank you so very much for
Thank you so much. Good night, all of you. Thank you so much.
Bye.
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 We are retelling their stories through our patented designs that can be worn on scrubs, t-shirts, printed on conference bags, and endless other promotional materials. Daily Wear for Medicine is the first ever of its kind to create curiosity in medicine through visual art. We at MedBricks are celebrating unsung heroes of the past who made enormous contributions to the field of medicine through our unique campaign called Daily Wear for Medicine. You can wear it, carry it, and give it.